This recording will cover part 2 of Parkinson's disease. So what are our priority problems for a patient with Parkinson's disease? The number one priority is decreased mobility and possible self-care deficit related to muscle rigidity, tremors, and postural instability. So the decreased mobility, again, we worry about falls, and with the muscle rigidity, don't forget another safety issue we have is aspiration and choking. Also, there's a potential for decreased self-esteem related to impaired cognition, tremors, and self-care deficit. Interventions for Parkinson's disease revolve around promoting mobility and promoting self-esteem. Care for the patient with Parkinson's includes drug therapy, exercise programs or PT, and interprofessional collaboration to promote mobility and self-care and prevent falls and other injuries. Drug therapy used to treat Parkinson's disease includes dopamine agonists, which mimic dopamine by stimulating dopamine receptors in the brain. Ropinirole, brand name Requip, is a common dopamine agonist that you see in the clinical setting. Your textbooks list carbidopa, levodopa as a dopamine agonist also. It's more of a dopamine replacement since it doesn't stimulate, it does stimulate the receptors in the brain, but what happens is the levodopa gets converted to dopamine, so it's considered a dopamine replacement. But it is a very common medication prescribed for Parkinson's patients. The brand name is Sinemet. And if you remember, the reason these two drugs are combined, levodopa is the drug the patient needs. That's the medication that will get turned into dopamine. But if you give levodopa by itself, the patient needs high dosages for enough of the levodopa to reach the brain where it needs to be. Because what happens is it gets broken down in the periphery when it's circulating through the body before it reaches the brain. Carbidopa is like the armored car that keeps levodopa intact until it actually crosses the blood-brain barrier and is in the brain to be converted to dopamine where it needs to be. So carbidopa prevents levodopa from being broken down too early. It gets it to the brain where it can then be turned into dopamine. I think that's it for that. The COMT inhibitors as well as the MAO-B inhibitors, we're looking at ACEs here. So we know these are enzymes that we're preventing or we're inhibiting. So inhibiting COMT, inhibiting MAO-B. So with COMT inhibitors, we're blocking enzymes, the COMTs, that inactivate dopamine. Remember, the problem with Parkinson's is not enough dopamine. So by blocking down enzymes that inactivate dopamine, it allows more dopamine to be present. The MAO-B inhibitors blocks the enzyme MAO-B that metabolizes dopamine, and that allows more dopamine to be present. So the drugs you want to know, the carbidopa, levodopa for dopamine agonists, entacapone for COMT inhibitor, and selegiline for the MAO-B inhibitor. And remember, with the MAO-B and MAO-I inhibitors, we want to teach the patient about tyramine. So when you think about tyramine, you should be thinking one thing. Are you worried about your patient being hypotensive or hypertensive? It should be hypertensive. So if a patient is on an MAO-B inhibitor and eats food high in tyramine, and the big ones are aged cheese and wine, the patient would be at risk for a hypertensive crisis. When other drugs are no longer effective, bromocriptine may be prescribed. It is a dopamine receptor agonist and is prescribed to promote the release of dopamine. Amantadine is actually an antiviral medication, but it is used because of its anti-Parkinson's benefits. It can be given early in the disease to reduce symptoms. It can be prescribed with carbidopa, levodopa to reduce dyskinesias. Benztropine is your prototype anticholinergic that you want to be familiar with. These anticholinergics may be prescribed for severe motor symptoms such as tremors and rigidity. They're rarely used as the primary drug of choice for Parkinson's. These drugs should be avoided in older adults because they can cause acute confusion, urinary retention, constipation, dry mouth, and blurred vision. Remember, those are our anticholinergic side effects that are undesired for older adults. We want to use newer and safer medications for this age group. Your textbook also lists rivastigmine, but don't get that confused with the medication that's being used to treat Parkinson's. It's a medication being used to treat Parkinson's-related dementia. So you should remember rivastigmine is a cholinesterase inhibitor. It allows more acetylcholine to be in the brain to help slow progression of dementia. When drug tolerance is reached, the drug's effects do not last as long as previously. The treatment for PD, drug toxicity, or tolerance includes a reduction in drug dosage, a change of drug or in the frequency of administration, and a drug holiday, particularly with levodopa therapy, where the patient wouldn't take the medication and it typically lasts for up to 10 days. There are other medications that are given for symptom relief. So baclofen for muscle spasms, that's your muscle relaxant. If the patient is having problems with drooling, atropine sulfate. If you remember, atropine is an anticholinergic. That's the one where I would draw a little arrow of the T pointing up and the P pointing down because something goes up, something goes down. What goes up? Heart rate, right? It can be used to treat symptomatic bradycardia. What goes down with atropine is secretions. So a lot of times it'll be given pre-op for patients in surgery, but in this case, for excessive drooling in the Parkinson's patient, they can take atropine. Problems with insomnia can be treated with zolpidem tartrate. And then finally, if the patient is experiencing depression, they can get an antidepressant such as venlafaxine. So now we're going to go over some other interventions for the patient with Parkinson's. A freezing gait and postural instability are major problems for the patient with Parkinson's disease, and non-traditional exercise such as yoga or Tai Chi can help elevate mood and improve mobility in the early stages of the disease. We also may want to get PT and OT on board. We want to remind the patient to avoid concentrating on his or her feet when walking to prevent falls. If the patient is hospitalized for any reason, be sure that he or she is placed on fall precautions according to agency policies. We want the patient to remain as independent as possible with their ADLs, and occupational therapy can set them up with adaptive devices to help that happen. I remember one gentleman would use a weighted spoon or weighted utensils. Because of the tremors, he was able to manipulate the weighted utensils better. Patients with Parkinson's do not sleep well at night. We want to monitor their pattern of sleep and discuss any issues or safety risks they may have because of lack of sleep, such as driving or operating machinery. We want to collaborate with a dietitian to evaluate the patient's nutritional needs and with a speech-language pathologist to evaluate if the patient is having problems swallowing or get them help with any speech difficulties that they may have. The patient may benefit from small, frequent meals and using things such as Thicket, which can thicken up liquids if they're having difficulty swallowing. Be sure to elevate the patient's head to allow easier swallowing and prevent aspiration. You want to weigh the patient weekly and monitor their weight and use supplemental feedings if necessary. Surgical management includes a stereotactic pallidotomy and also deep brain stimulation. With a pallidotomy, the surgeon creates lesions within the brain that create a scar, and this helps reduce the brain activity in the area where the scar is created, which helps relieve movement symptoms such as tremor and stiffness, rigidity. With deep brain stimulation, electrodes are implanted into the brain and connected to a small electrical device called a pulse generator that delivers electrical current. The generator is placed under the skin similar to a cardiac pacemaker device. It is externally programmed to deliver an electrical current to decrease involuntary movements known as dyskinesias, resulting in a reduced need for levodopa and other drugs. Although not all patients with Parkinson's have dementia, impaired cognition and memory deficits are common. In the late stages of the disease, they cannot move without assistance, have difficulty talking, have minimal facial expression, and may drool. They may be embarrassed or ashamed and have difficulty doing any sort of activities. Teach the family to emphasize the patient's abilities or strength and provide positive reinforcement when he or she meets expected outcomes. The family or members of the team need to make sure that they're setting realistic goals that can be achieved for the patient. I'm going to go ahead and let you review the care coordination section on your own. In terms of evaluation and reflecting to know, are we doing what's needed to be done to treat the patient with Parkinson's? We want to watch for improved mobility, to provide self-care and not experience complications of impaired mobility. And also we want to see the patient maintain a positive self-esteem and acceptable quality of life.